I'm just going to get started introducing our next speaker, Dr. Emily Levin. She holds a joint appointment at the University of Michigan and the Ann Arbor VA Medical Center. She graduated from the University of Pittsburgh School of Medicine and completed her surgical internship and residency in neurosurgery at the University of Michigan. She then went to the University of California, San Francisco, and completed fellowship in stereotactic and functional neurosurgery there, which is one of the leading centers in the nation, or actually maybe even the world, for deep brain stimulation and functional neurosurgery. She has a particular interest in the use of technology to improve outcomes and the patient experience during neurosurgical procedures. And she'll be talking a little bit about deep brain stimulation for Parkinson's disease. Let's welcome Dr. Levin.
Good morning. Thank you so much for inviting me to speak with you today. So I want to just build on what we talked about earlier this morning about Parkinson's disease and then focus specifically on the surgical treatment of it. So you've heard deep brain stimulation and you've heard a little bit about what it is, but I'll go into that in more detail. Deep brain stimulation involves placing a small wire deep into the structures of the brain and connecting it to a pacemaker in the chest, which allows small electrical pulses to stimulate the brain and improve the symptoms of Parkinson's disease. Now, there are 3 typical sites deep in the brain where we can place these electrodes, and I just show you this to give you an idea of their size. And they're about 1/4 of an inch, and we're trying to get these electrodes precisely into these structures deep in the brain. So it does take a little bit of work to get them there. The advantages of deep brain stimulation over the old surgery, which is where we would actually burn these areas of the brain many years ago, are that without burning the brain, you can actually make changes and actually reverse any of the problems that could have happened with doing the surgery. With the old burning surgery, you could only do it on one side of the brain, so you would only be able to treat one side of the body. And you can adjust the stimulation so that you can maximize the benefit for the individual without having too many side effects. So what does deep brain stimulation do for you? So this is a typical individual with Parkinson's disease, kind of an extreme example, but you're seeing he's got significant tremor. And he actually, if we let the video play a little bit longer, you would see that he's got some difficulty getting going as well. He's off of his medications. You've also seen that some patients have problems where you're on your medications, and the medications cause these really fast movements, which are called dyskinesias, which we heard about earlier this morning. So this is a side effect of the Parkinson's medications. So what deep brain stimulation can do is help you smooth out what those medications are doing to you. So you have less off time and less peak dose dyskinesias. So you get fewer of the side effects from your Parkinson's medications, and you get just a smoother effect of your medications throughout the day. And this bears out in big studies of patients who have had deep brain stimulation versus just taking medications, and that it doesn't make you any better than the medications do, but it gives you more hours in the day of having good effect of your medications. So the goal of deep brain stimulation is to make your life better. So in the top video here, this is that individual with no medications, and his deep brain stimulator is off. And now in the bottom, it actually looks like the video isn't working. He's that smooth. The tremor is really helped by the deep brain stimulation. So who is an ideal candidate for getting deep brain stimulation? So a person who has Parkinson's disease, and that, as we talked about earlier this morning, is done by a careful history and a physical examination. And we're making sure that you don't have one of the other Parkinson's disease mimickers. And somebody who has symptoms of their Parkinson's disease that's not being controlled by medication. So you have Parkinson's disease, you're responding to the dopamine medication, but you're having some of the side effects. You don't have dementia, you don't have thinking and memory problems, and you don't have significant untreated depression. So, as I've mentioned a few times, the response to dopamine medications like Sinemet or the dopamine agonists is really the most important indicator of whether deep brain stimulation is going to work for you. So we actually, if we're thinking about deep brain stimulation as a treatment for you, your neurologist will examine you off of your dopamine medications and then on your dopamine medications to make sure that there is a significant improvement in your symptoms with the dopamine medication. The deep brain stimulation will not make you any better than your dopamine medications do when they're working at their best. And the things that don't respond to medication, like the thinking and memory difficulties, the autonomic difficulties, and some of the walking difficulties, won't get better with deep brain stimulation. As I briefly mentioned before, you can't have deep brain stimulation if you have dementia. So if you're having memory problems, deep brain stimulation can actually make it worse, and that doesn't make sense. We don't want to make you worse. Also, if you have severe depression, deep brain stimulation can make that worse as well. So we want to make sure depression is treated before pursuing deep brain stimulation. So when would you consider having deep brain stimulation? If you're having only mild symptoms, they're controlled well with your medication, you're not having huge fluctuations going on and off throughout the day, deep brain stimulation isn't for you. But when you're starting to have issues with the medications, you're getting a lot of dyskinesias, or you're having a lot of wearing off time, that's the time to start thinking about deep brain stimulation and discussing it with your doctor. That being said, it's best to have surgery when you're younger. The older you are, the higher the risk of complications. So, we want to weigh those risks and benefits. And remember that deep brain stimulation only helps the symptoms that are helped by your dopamine medications and will not improve your speech, will not improve your walking typically. So, where do you go for deep brain stimulation? You want to look for an institution that has a multidisciplinary DBS team, which includes a neurosurgeon who has specialized extra training in the placement of a deep brain stimulator electrode, a neurologist who has specialized extra training in the programming of a deep brain stimulation system, a neuropsychologist who can evaluate you for whether you've got early signs of dementia or depression so that we can know that ahead of time and not make those things worse. And having a nurse coordinator who can help get you through the whole process of dealing with a number of different appointments and a surgery is really helpful. A lot of DBS teams also include speech pathologists, social workers, nutritionists, and psychiatrists to help with managing some of the issues that can come up around the time of surgery. So there are currently two types of surgeries for placing the electrodes deep within the brain. The goal of both of them is to accurately put the tip of these thin wires into the structures in the brain that I mentioned to you before. But there's a more traditional way of doing it, which is with the patient awake, which some of you have probably heard about. And then there's a newer way of placing the electrodes with the patient asleep. So I'll start with the traditional surgery, which is awake deep brain stimulation. And the way that we get the electrode accurately into its place is by putting a frame on your head, usually with numbing medicine so that you can't feel the pins, but they do go into the skin in your forehead and the back of your head. And then that allows us to accurately identify where your brain is and where those structures in your brain are to allow us to put the electrode in very, very accurately. This is an individual who had the frame placed. And you come in on the morning of the surgery and the frame is placed. As I said, your scalp is numbed so that you don't feel it. You might feel some pressure with it, but it shouldn't be painful. And your family can be present to support you if they're okay with that. Otherwise, we're happy to support you too. You would then go and have an MRI or a CAT scan to see your brain in relation to that frame that's been put on. And this is an example of what it looks like. You can kind of see the square of dots around the picture of the brain in the center, which is how the computer can tell us exactly where the frame is in relation to your brain. We then plug this into our GPS system in the operating room, which is a very, very expensive special computer system that helps us tell exactly how to set up the frame in the operating room to get the electrode where it needs to go. And this is what you would experience in the operating room. You are seated as comfortably as possible in the operating room, and this clear drape is put on to allow us to communicate with you during the surgery. There's an X-ray machine that'll go around you so that we can see the electrode as it goes into your head and make sure it's going to the right spot. And there should be absolutely no pain with this surgery. So numbing medicine is used. You are awake during it, but sometimes a little bit sleepy so that you aren't getting too bored, because it can take a little bit of time. This is the arc which allows us to accurately put that electrode into the brain, and that attaches to the frame that's placed on your head. We use that arc first to put a microscopic needle into your brain, which allows us to actually listen to the cells in your brain as they are firing. And we're able to use the sound of those cells to confirm that, yes, we're in the exact place that we want to be. When we've done that, we then take the microelectrode out and replace it with the deep brain stimulation electrode. This is the one that stays in place. And this is what it looks like. It's really only about the size of a piece of spaghetti. It has 4 metal contacts on the end through which the electricity flows. And then that's an X-ray picture up here where we can say, yep, we got it right on target, exactly where we want it to be. Once we've got the electrode into place, then we will turn it on and test you for change in your symptoms. So we'll be looking for changes in tremor and changes in the stiffness. We'll also turn it all the way up and look for side effects so that we can know, is this in a good place, or is this in a position where the side effects are coming on with too little stimulation and we should maybe consider moving it. Often there's a speech pathologist, a neurologist, and the neurosurgeon in the room going through all of that testing with you, because we're looking for speech changes that are side effects sometimes of the deep brain stimulation. After the electrode is put in, you'll get a CAT scan to make sure it's in the right place. And that's pretty much the awake surgery. Now we'll move on to the newer asleep surgery, which uses the same principles, but we now are able to do surgery in an MRI scanner. So what we do is we take you into the MRI, you're actually put totally to sleep, get an MRI to look at your brain, and we put an MRI visible aiming device onto your scalp, which allows us to adjust the aiming device using the MRI to align it with the exact target in your brain where we need to place the electrode. You can see this is what the aiming device looks like here, and this is what it looks like on MRI. So you can see that it's pretty clearly visible. And the computer software and the MRI show us where we're aimed, where we're targeted, and tells us how to adjust the aiming device so that we can get to the correct target. And then in real time, we can watch the electrode being placed in the MRI to make sure it's going to the correct place. And in the first major studies of this, because this is a newer technology, the outcomes, the response to deep brain stimulation, whether you've had awake surgery or a sleep surgery, are essentially the same in with an experienced surgeon. So why would you choose awake or a sleep surgery? Well, it's really the patient preference. Some people would not tolerate being awake. Some people have anxiety about having surgery while being awake. Some people have difficulty being off of their Parkinson's disease medications, which is something that we require for awake surgery as well, and have painful cramping or things like that during the surgery, so wouldn't want to be off of their medications for an awake surgery. Other patients feel really strongly about being awake for the surgery. I've had people who would be self-described control freaks and and want to be awake for the surgery. So I can completely understand either way. After the electrodes have been placed in your brain, they need to be connected to the pacemaker. So this is usually done a few weeks after your original surgery. It's an outpatient procedure, and it's very similar to a pacemaker placement like you would have for a heart pacemaker. The wires are tunneled underneath the skin from up on top of your scalp where the wires go into your brain, back behind your ear to a pocket in your chest where the generator sits. The risks of deep brain stimulation are the risks of brain surgery. It is brain surgery. There's a risk of stroke. There's a risk of damage to the brain itself. These are pieces of hardware that are made by humans, and so sometimes they don't work right. So there's a risk that if the hardware, the wires, or the generator itself isn't working correctly, it might need to be replaced with surgery. And there's a risk of infection with all surgeries. There can also be effects of the stimulation, which are not things that we would want, like I mentioned before, changes in your speech, changes in your mood, changes in your thinking or memory. And we do everything we can ahead of time to minimize those things, but sometimes we start stimulation and see some of these side effects and have to adjust stimulation to avoid them. What happens after your DBS surgery? Well, the most important thing about getting your deep brain stimulation is not only having the electrode put in exactly the right space, but having someone who is then experienced in programming your deep brain stimulation system to get the best outcome out of it. So, and your programming of your deep brain stimulation system is just as important as getting the electrode in the right place. We usually wait until some of the brain swelling has had a chance to go down before doing any programming, because otherwise that requires frequent changes. So usually about 2 to 4 weeks after your original surgery. And as the stimulator is being turned on, sometimes we have to turn down your medications so that your dyskinesias, which can be worsened by stimulation, can be improved, and get, again, a more smooth control of your symptoms. In one of the targets, the subthalamic nucleus, there's been a good history of being able to decrease your dopamine medication so that you don't have to take it so frequently throughout the day. But the important thing to remember is that the surgery is just the beginning of this process, and it can take 3 to 6 months to get your stimulation programmed appropriately to get the best benefit. So is deep brain stimulation right for you? Do you qualify for deep brain stimulation, or do you have one of those problems that I mentioned with dementia or depression? Are your symptoms interfering with your quality of life, and are you willing to accept the risks of surgery? Just a plug for Dr. Chu's book on deep brain stimulation. And do you have any questions?
Oh, thank you. Couple questions. One is, how many does the U of M do in a year's time?
So probably on average, a little over 50. It's typically 1 a week on average.
Okay,
Yeah.
I was curious about that. And then like the gentleman that was shown earlier, as far as his tremors were quite pronounced, so how would he do the awake procedure to have him still enough for the precision that you need?
It can be difficult. So the reason the frame is placed on your head is the frame is actually locked down to the table to prevent the head from moving. Good question.
I had a question. Can you explain what does a deep brain stimulation do that replaces what the medicines do? Or
If I knew the answer to that. So when I started becoming interested in deep brain stimulation, we thought that it blocked the transmission of signals in the area of the brain that you place the electrode, because it acts like you caused a stroke in that area. But what we're realizing is that it's more of an information lesion. So signals, the neurons are still firing, but the signals just aren't getting through. That's what we think right now.
Did the DBS and the medical comparison include long-acting amantadine hydrochloride?
I'm sorry, sir.
Long-acting amantadine, has it been compared to DBS in control of dyskinesias?
So in terms of comparing deep brain stimulation directly to long-acting amantadine, I don't think that's been individually compared, but best medical therapy, including long-acting medications, has been compared to deep brain stimulation. And deep brain stimulation is superior in the amount of good on time without dyskinesias.
What about ultrasound?
So high-frequency focused ultrasound has become approved for the treatment of essential tremor. What that does is creates a lesion in the brain, just like the old-fashioned way of doing it with burning. It's only able to be done on one side, and in the US it's only approved for essential tremor, but it's being done for Parkinson's disease as well. It's theoretically a less invasive surgery because it doesn't involve any cutting. And it's currently only available at University of Virginia in the United States. Yeah, and not reversible, exactly.
You probably mentioned this under your slide, when to consider DBS. You probably said this and I missed it. You indicated under mild or moderate symptoms need for LD. And what is LD?
Levodopa or Sinemet.
Okay.
Sorry about that.
Thank you.
I imagine that most of the patients with Parkinson's have Medicare. Is it covered by Medicare?
Yes. So there are three different targets. The thalamus is one that's best for tremor. The subthalamic nucleus and the globus pallidus are two other, don't worry about them, I can spell them for you if you, yeah. Mm-hmm. There are three different separate deep brain structures that are used. Yeah. Absolutely. Physical therapy both before and after surgery are actually really important. I have not noticed that in my experience. Have you?
After deep brain
Yeah. Yeah.
Is there a failure rate?
So in terms of device failure or in terms of patient not getting the expected benefit from it?
The former.
Okay, so the devices fail incredibly rarely. The highest risk of failure is that the wires that go into the brain are incredibly thin, and so with movement and time, some of those wires can break. Usually that doesn't mean we have to change anything, but sometimes it means we have to change which electrode is being actively used. It's very rare that we have to do additional surgery for it. I'd say probably 1 in 1,000 because of a device failure. The generator itself lasts 3 to 5 years, depending on what your stimulation settings are. Oh, yeah. Yeah, if anyone didn't hear, he asked, how long does the device last? Which is about 3 to 5 years. Yes, it is easier if you get the heart pacemaker after the deep brain stimulator.
mostly misfiring of the cells, like your synapses of the nerves?
So it's actually cells in the brain that are dying.
Okay.
And so that there's an imbalance in the types of cells in your brain. We can talk more after. Yeah.
I've heard that there are, this programming essentially gives a constant signal versus a later development which is in some way variable and in response to what's going on in the brain. Could you tell us more about that?
Absolutely. That was actually the focus of my research when I did my fellowship. So we're looking for signals in the brain that tell us that symptoms are coming on. So are there signals in the area of the brain that controls movement of your arms that we can use to say, let's turn the stimulator on now because symptoms are about to happen? We're not there yet, but the devices are there. The devices that are able to sense brain signals and then change based on those brain signals exist in non-FDA approved form just for research purposes. We'll wait for the microphone, it's coming.
Thank you. Out of like the 50 that you do in a year, what is the success rate of symptom benefits?
I am hesitant to say all, but nearly
Most
everybody.
people feel
yeah,
better.
Absolutely.
So have you done all the patients who have tremors, or have you done the people who just had rigidity?
So both. It's helpful for both tremor and rigidity.
But not necessarily with the gait, right?
Exactly.
Okay.
The freezing of gait doesn't usually get better, that being stuck.
What about fascination?
Not really. Yeah.
No.
Yeah.
So in terms of gait, fascination, freezing, it actually depends on how well you do these types of things when the medication is working as opposed to the medication is not working. So typically what happens is medication kicks in, Sinemet kicks in, you're on medication, makes the symptoms better. If your walking is good during your on time and you have no freezing and no fascination, but then when it wears off, that's when you have it, then deep brain stimulation will help the gait because it actually helps the symptoms that are helped by levodopa or Sinemet. So when you're on, that's as best as we can make you. So what we're trying to do is make the off time more like the on time. So if on time, you have no problems with gait, no freezing, no fascination, then the deep brain stimulation will help you. But there are people who, when they're on medications, will still have fascination and still have freezing, and in those patients, we can't make those symptoms better. I hope that clarifies things a little bit.
Well, thank you. I'll be available for any other questions during lunchtime.